Good afternoon, esteemed colleagues, distinguished guests, and our dear participants, both in person and online. It is my great pleasure and honor to welcome you all to the first Patient and Public Engagement and Involvement Summit. My name is Dr. Arisha Hosseini, and I am one of the coordinators of the PPIE group of the Ziauddin University Clinical Trials Unit here in Karachi. Today, we are privileged to bring together local experts and leaders of health research to discuss the future direction of patient involvement in clinical research. At the heart of this summit lies a shared passion to advance patient engagement initiatives, support the creation of new collaborations, and PPI groups that can drive meaningful change. Details of all of our speakers today can also be found on our website mentioned here. Before we proceed, I would kindly ask everyone to please turn your phones to silent mode so as to ensure a smooth and uninterrupted experience for all. Without further ado, it is my honor to invite Dr. Zulfikar Ali Umrani to the stage to inaugurate our event. As the Director of Research, Innovation and Commercialization and the Director of the Ziauddin University Clinical Trials Unit, Dr. Umrani brings invaluable insight on research for impact. Please give a warm welcome to Dr. Zulfikar Ali Umrani.
Thank you, Dr. Abhishek. Esteemed guests, friends, I see some students also. A very good afternoon and assalamu alaikum. Today is an immense pleasure to be opening this Patient Public Involvement and Engagement Summit taking place at Ziauddin University. It's being live telecast across the world. I know that we have some speakers joining us from University of Oxford. We are thankful to the busy people here in Pakistan, Dr. Saeed Hamad, Dr. Adnan, Dr. Nikhar, who have consented to be the speakers for this session. And we have friends from PILS also joining us. We are thankful to them. This journey for the PPI, I remember it was back in October 2022 that Arishe, along with Dr. Timo and under the supervision of Dr. Madia Hashmi, who I also think is hearing this event in Singapore, maybe. So it was in 2022, they were going through the proposal submission and we were having discussions on how to seek funding for this initiative. And it was officially started last year in April. I didn't quite understand what this project was about back then. PPI sunte the, lekin pata nahi tha kya hai. But I've seen the wonderful work that Dr. Arishe and others of Chemo have been doing on this project, bringing together the patients, the public, the community stakeholders, and the clinicians and researchers together for more democratic and better designed trials. We are really happy that, and we appreciate the efforts that they launched the first ever PPI group in Pakistan in any CTU. So this accolades and kudos to the team here. Now, this is just the first step. That is bringing the patients and their carers and the public together on the table to discuss what are clinical trials. That was one of their outcomes also. 70 to 80%, that was the outcome from our open house. 70 to 80% of the public didn't even know what clinical trials were, let alone bring their input to it. So now that they have started the work, engaging with the public, what we can hope for is better design trials, that is putting their input. Another thing that we need to do as we move forward is bring the CROs and the sponsors also involved in the process, so that these findings that were coming out from the PPIE group can lead to better input when the trials are being designed by the sponsors and the clinicians. And the third thing that we need to look at is, because I know the project is actually coming to an end, so we have to consider the sustainability of this initiative. I think this is a critical initiative that all the CTUs require. So I think one of the things that RAP could actually play a role in is have PPI groups for all the CTUs and the university and the external funding bodies, because NIHR has supported this PPI initiative across UK. So we also need to look at how we can sustain this initiative post the project. But I'm really glad that we have started this journey and it can lead to better outcomes for the patients through their involvement, through the public involvement. And I look forward to some wonderful speeches. Thank you very much.
Thank you so much, Dr. Zulfikar, for always being so supportive for whatever we try to engage with and for all your thoughts that you shared, which we will now further explore in our panel discussion as well. I would like now to introduce a key member of our PPIE group, a coordinator of one of our PPIE group, Professor Nikat Ahmed Siddiqui, who is a neuroscientist with over 40 years of research experience, and she has done us the honor of joining our group and helping us and supporting us throughout this initiative. She'll be speaking about the PPI group here at Ziauddin. So please, a warm welcome, Professor Nikat Ahmed.
Assalamu alaikum. Good afternoon and good day for all of our worthy participants who are present here and who are online. Here we have gathered to discuss the challenges and opportunities for public engagement in research in Karachi. And it is a moment of immense pride for me to introduce PPI on behalf of my group and my team to this gathering of researchers, local experts, and leaders of public engagement, patients, and all those here and online to celebrate and together discuss the road taken by Ziauddin University of excellence and humanity, I called it. We are the first ever PPI group in Pakistan, as Dr. Zulfikar mentioned. Together we can foster a world where humanity and compassion triumph and healthcare can be improved. So patient and public involvement and engagement in clinical research, it is basically now an international movement, and PPI aims to transform the healthcare landscape across Pakistan, focusing not only on clinical trials unit, but also on other specialties. What is PPI? PPI is basically a concept. It involves three pillars: involvement, engagement, and participation. And the initiative we have taken is working with patients, their families, and the public to shape and influence the research. And that is what is called patient-public involvement and engagement. And for short, I'm going to use the word PPIE sometimes. And this PPI group actually will try to achieve a world where we can have health research as an integral part. Through this, we can achieve our mission to improve the way we conduct trials, which is one of the important missions of ours, and to make them more relevant, meaningful, and beneficial to the community in Karachi and in Pakistan. So here is the members of the Ziauddin University Patient Public Engagement Group. And you can see here Professor Dr. Madiha Hashmi, and she is the lead here. Then we have our group members, and these group members are the one which we cherish a lot, because we think that these are the people without which it is not possible. So we have Shehnaz, Munazza, Shehla, Natasha, myself, Arishe, Zahid, Shanil, Adnan, Saima, and Dr. Timo. Dr. Timo, Arisha, and myself are the coordinators, and rest are actually the essence of the group who are developing patient public involvement and engagement in Pakistan. So here you can see that almost after a year of inception, because we started in June 23, basically in April 2023. So after inception, we are in a position to critically reflect on the challenges and success of our group. And the most challenging part of this was identifying the group members. And we have to identify the group members from the patients and the families, that is, the people with lived experience of clinical trial units and or maybe in some cases intensive care units as we had in COVID. The NGO workers, the non-governmental organization workers, the public, and it was a challenging task and it took more than what we thought that the time. So it was basically longer than our expectations. But we are we are very lucky to have a very diverse group because the people, the members of our group almost represent, if you look up at this chart of Karachi diversity, which I have taken from this World Health Organization data, and it is changing sometimes with the people migrating from one city to the other. But this represents diverse ethnicity in Karachi, and we are lucky that we have in our group members who represent Pashto, Punjabi, Saraiki, and Urdu. So I can say that 50% of the ethnic representation is there. So we do represent to some extent the diversity of Karachi. Then we have project evaluation, which is another challenging task. The processes and outcomes and measures, the testimonials, and the most significant change technique which we have used. And this most significant change technique is a qualitative and participatory form of monitoring and evaluation based. And this is what we have used. And as we get the information, the stories, so we can change the development which is going on. So here there is a spectrum or range of engagement which is involved, and people are recruited to the clinical trial or other research, and that is called participation. I'm sorry, the slide is not coming correctly. The letter is here instead of here. Anyway, and involvement, information and knowledge about research is provided and disseminated, which is called engagement, and active participation between patients and member of the public with researchers that influences and shape research is what we call involvement. So this is a range of a spectrum of engagement which is utilized in the formation of PPIE, and this partnership, this active partnership is used for information and knowledge about research and increasing the dimensions of research in clinical trial unit in Karachi. So we also adopted some strategies for participation and engagement for enhancing the participation. And this strategy, the strategies we used here is basically utilized because we believe that PPI is central to establishing trust and confidence. So it is very important to have a communication, and that communication is to keep and retain the members as well, and regular updates about the progress of PPI activities. So this is also one of the challenge because time of the day, the meeting format identified as a challenge, and the affected who could be able to attend the meeting. Remember, we called our fellowship of willing volunteers who are the part of PPI group, and this we enjoy the term fellowship of willing volunteers because these are the volunteers who are not basically has a full-time job in PPIE, but they are just compensated for their time and they are giving their utmost commitment here in PPI, information and working of the PPI group. The next important thing is the feedback, and feedback is important because we want people to give us the information and the group members to give the information or the problem they are facing. And this feedback, we have implemented the system for collecting and addressing the feedback so that we can improve as we go about with the group activities. Promotion. Promotion achievements are promoted through social media, conferences, events, and seminars. And I'm going to tell you in a minute about the details of what we have been doing so far. Progress thus far. So what we have achieved is first is the establishment of the first ever PPI group, which consists of course, patients, their families, the public, and the community workers, and created research materials in a relevant format. Like I talked about earlier, that basically the group is engaged initially in the development of a consent form, informed consent form, used at the critical clinical trial unit by the patient to make it more understandable and in a more simple language so that it will be easy to understand by the patient. So we are formatting the informed consent process for Megarox and DMAP-CAP trials, and we have organized a public event and produced a video to inform the community about trials. And these were the short-term objective of developing the informed consent form. Beside this, we have the long-term objective, that is to promote awareness of PPI, which you all know that we are working very hard, developing the ways of sharing knowledge and experience of PPI, and also assessing the impact of PPI. And this is basically our long-term objective, because making practice and policy, it is quite difficult in this country. So to assess the impact of PPI on research practice and policy, we'll try our utmost to bring PPI to such a level that it can have a say or a word or a voice at the ministry level. So the major important target of us is the building capacity in PPI across South Asia and to develop international standard and policies for PPIE. So the impacts and the output, this is what we have achieved so far. My involvement profile, co-created terms of reference, ethics training, this has all been done. And this ethics training, we have utilized the bioethics committee of CVAC of SIET, the clinical trials training, that is the processes of research, the request form, that if somebody is interested in asking, involving the PPI members to improve the clinical trial research. We have our 2 newsletters. We have our PPI website in place, a video on PPI in Urdu, and the most amazing, the animated clinical trial video, which is coming in Urdu, Pashto, and Sindhi. Evaluation protocol and open house event. And open house event is the main purpose of the open house event was to bring the voices of the underserved community so that they can come up and they can share their experiences. This is the timeline of our PPI journey. We started in June 2023, the signing of charter with Ziauddin University. Then we have lecture on PPI trials. What is PPI trial? Then we were lucky to develop the website of the PPI, which goes live. And this was one of the achievements, I think. It was exposure to the large community. And then we have our first meeting of ZU PPI group. And I must say that it was we were so excited and we were so, I can't tell you, overwhelmed that we finally achieved to form a PPI group, including all the challenges we have of the time and the meeting time and the place of time, and besides funding and others, that we had the first meeting in 2023. That was, I can say, the milestone we placed Then we have our acute care colloquium. This is the global outreach where you can see the presentation of our PPI members in Canada. Then Remap Cap global meeting, which was online. And then we have teaching for nursing students. This was conducted as well for nursing students because the nurses are an integral part of the critical clinical trial units. So it is important that they know about how to go about the system and what the research is about. Then we have our open house, as I told you. Finally, we determined the impact on various groups and communities. First is the PPI group member, that is to develop knowledge and skills so that these members can actually be an advocate for patient and community. As a PPI coordinators, it was also very learning experience, and we have developed skills in science communication because one of the language barrier was language. And so what we decided in the meeting to change to use Urdu language as a device, as a tool, so that it is easy for the understanding and communication among the members as well. Then we have patient and families, which has got the impact on by improved informed consent and understanding of trials. So these families now in a position to better understand the trial and to go about the informed consent procedure. The trial staff, they have improved communication with trial participants and the families. They got trained in a way. General public, greater awareness of research clinical trials and trial results, clinical trial unit itself, because it is a sort of support to make trials more impact and efficient. Then we have the trials, different trials which is going on in clinical trial units, that is more ethical trial conduct and improved recruitment rates and also transparency of the trial. The last impact, I think, will be once we will have other PPI groups and the support for establishing PPI group in Southeast Asia and beyond. So what we have finally concluded from this, that PPI is a reality, it is acceptable, it is relevant to Pakistan, South Asia and other low and middle income countries or settings. Collaboration and engagement as widely as possible is very, very important. Sufficient time for recruitment and setup to be allocated, as I mentioned, that we thought we can recruit the group members in 1 month, it was impossible. Then visibility of ZUPPI Pakistan across the globe. I would like to acknowledge MORO, the Mahidol Oxford Research Unit of Tropical Health Network for providing the funding. PRICE, Irish Critical Care Trial Network, Remap CAP, CBEC, Megarox, and the marketing team here. Zufanab, Dr. Pamela and Marshall and team, PIL, CI group present here, CBEC, Professor Ahmed Jafri, Nida Wahid and team, and of course, the clinical trial unit team, Dr. Zulfaqar Umrani, Mansoor Khan, and the team. So I'm really, really thankful to them. And most importantly, I would like to express my deeper gratitude to our Fellowship of Willing Volunteers, that is our group members who have generously dedicated their time and effort to support this cause of community. And it is their compassion and dedication is really, truly aspiring. We are also humbled and grateful for the incredible outpouring of support and enthusiasm for PPI. The passion for including the patient voice in clinical trial has touched our hearts deeply. And I would like to say is that PPI is for everyone and anyone can join in. So we can go to our website, find the links, join in, go through the activities of the PPIs. And at the end, I would like to Thank you all, because now we have determined that PPI in Pakistan is a reality. Thank you, and
Thank you, Professor Nikhat, for this excellent presentation and introduction and covering exactly what we have set out to achieve and what we've been able to achieve in all this time together. It is now my distinct honor to introduce our keynote speaker, a visionary leader in both medicine and research. Professor Dr. Saeed Hamid, a professor of medicine and director of the Aga Khan Clinical Trials Unit, has authored over 200 publications which have changed the face of patient care. We are deeply privileged and grateful for his presence and participation today. Please, for a very warm welcome to Professor Dr. Saeed Hamid.
First of all, thank you very much for the kind invitation. But let me just confess right at the start, this is not my area of expertise, so please don't be disappointed if I don't say all the right things. It was difficult to put together this this particular talk because there were so many aspects to cover. So I'll try and give you some thoughts from. Do I need to? Okay, yeah, we got that. Okay, so first of all, congratulations once again to the group who thought about this PPIE. It's a bit of a mouthful, but it is really an important mouthful, and not only conceptualized it but put it into practice. So thank you very much for doing this, and I think you need another round of applause. So you folks are leading this at Ziauddin, and I think this has to then disperse to other units and other people within the country. So I'll just focus on challenges and opportunities for patients and public engagement in clinical trials in Pakistan, giving you some examples of what we have been engaged in and what we've done, our successes, our failures, and what we could do better. These are my disclosures. So just a little bit of statistics before we start. This is just a map of South Asia, as you can see, and it is clear that we are well behind our neighbor, well, at least tenfold behind in terms of the number of clinical trials that are done. And if you wanted to go a little bit more west, which is Iran is almost close to 2,000 clinical trials, despite all the difficulties that they have in this geopolitical world. So we have a lot of catching up to do. And we have a lot of catching up to do because we are a huge country in terms of population, 250 million by the last account. Still, much of our population is rural, and therefore we have to think about ways of getting these folks into clinical trials and into the modern era of modern medicine development and so on. Our population is very young, less than nearly 50% are less than 50 years of age, and we know that most of the medical coverage is private. Our top diseases are diabetes. 30% of us are diabetics. And I put in hepatitis C because I'm a gastroenterologist, so that is my field. But still, we are the largest country in the world for hepatitis C and for other viral hepatitis. Not mentioned on this slide is another statistic which I forgot, and that is the penetration of mobile telephones, particularly of smartphones in our country. That is humongous in terms of if we compare it to other places, and that is a tool that is so useful in what is being done in terms of patient and public involvement. So let us start with a couple of success stories. Now, I don't want to bore you with a lot of medical stuff, but just to give you the background. So hepatitis Delta is the severest form of viral hepatitis that humankind faces, right? It kills people by the age of 30 or 40, and even at a younger age, young patients, we see with liver cirrhosis and end-stage liver disease and so on. It is always, as we know, it is always associated with hepatitis B. It needs hepatitis B for its proliferation. Until very recently, there have been no approved treatments for hepatitis delta. So it's been what is called an orphan disease. An orphan disease is something where the numbers are not too large, so less than 200,000 in a given population, and no disease, no approved medication for hepatitis delta. And why do we put so much emphasis on this? Because we are a big hotspot for hepatitis delta. The colored yellow area is, I don't have a pointer here, but maybe I can use this one. So the colored yellow area is the area which is our hotspot for delta. And as you can see, a large part of our province is involved in this. In some places, nearly 60% of our patients with B also have delta, so co-infected, right? So Upper Sindh, Lower Punjab, parts of Balochistan, this is where delta resides. This area is about 300, or some of these areas are between 150 to 300 kilometers or even 400 kilometers from Karachi, where all the trial activity takes place, right? So just to put it into context. So the only treatment we've had so far is interferon, which is not an approved therapy, but it is used because it's been used in other hepatitis conditions. And it does give you a little bit of a response. It doesn't give you a cure, but it gives you a little bit of response. About 30% may have a what we call a durable biochemical response, and they become negative for a while for delta the delta RNA, delta virus, but then they generally relapse. So therefore, there is need for drug development. Now, even if they don't, they're not cured, there is good evidence to suggest that their disease status is affected. So it is affected in a positive way, and they live longer, they have less liver disease effects, and so on. And therefore, this is something that can be used in terms of developing clinical trials for this condition. So then the point to make is that now there's a very active pipeline for experimental therapy. So there are lots of clinical trials that are going on around the world because people have now realized that Delta is not just a localized infection for certain countries, but it is a global infection that needs to be tackled globally. So some of the new experimental therapies are there. And it is nice to see that we are now heavily engaged in this in drug development for Delta. We were engaged with the interferon lambda studies, lonafanib, the monoclonal antibodies, and now hopefully with the small interfering RNAs. And quite a bit of this work we've been doing with Ziauddin as one of the centers and other places in the country as well. So lonafanib was the first oral therapy for hepatitis delta, the first large phase 3 study that was done globally. 23 countries, more than 100 sites, right? And the total sample size was about 405 that eventually got in. They came to us because they could not fill this trial. And we said, fine, we will do it as quickly as you want or as slowly as you want, but we've got the patience to do it. Now, here comes that concept, and I think this will probably be repeated during the day, that our patients are considered to be guinea pigs, and that there's nothing in it for them, and therefore this is all just big companies or big sponsors performing clinical trials without really a major advantage to our patients. And that is generally not the case. So we contributed 54 out of those 405 patients, which makes it 13% of the sample size. So the largest contribution was from Pakistan. Now, why do I say this? These 54 patients, if they had not come into this clinical trial, they would have not had any exposure to any therapy. They've already had experience with interferon therapy, and there was no other recourse, or there is no other recourse for these patients to get therapy, any kind of therapy. So these 54 patients are at least being treated by a novel experimental therapy, which hopefully is going to help them to some extent or maybe even to a large extent. And that is something that I think the PPIE initiative has to instill in people that there is benefit in this. So right. So here is the benefit. There were four arms. I'm sorry if you can't see the slide very well, but there were four arms. The blue one is lonafanib plus interferon therapy. And you can see that it is by far the best arm out of all these, including interferon alpha alone. Moreover, when you looked at the liver biopsies improved to a certain extent. So I think whoever got into the study had an advantage. It may be yes, there were side effects. Yes, there were issues in terms of the end results in some people. Not everybody responded, but many people did respond. This is the second study, the monoclonal antibody, which we are doing currently right now. And this is a novel therapy that is being looked at. A complicated trial, many parts to it. Treatment period for 24 weeks, 48 weeks treatment period, 24 weeks follow-up. So a large, long study. And the study entails that patients are, so we put in 45 patients in this study, which was the largest number that is there so far. If you look at the study schedule, and that is something that we will discuss perhaps later, it is a very intensive study schedule. Every 2 weeks, people are coming in for an infusion and then going home and coming back again, and a blood draw in many visits, and they're going home and then they're coming back every 2 weeks. So this is a huge commitment on part of these patients who are traveling fair distances to come every 2 weeks and to get these drugs, medications, and then go home. So the reason to demonstrate all this is, why is this happening? There was nothing magical of what we did, where we were so successful in filling up these trials and moving them forward and getting other trials in return and so on. It's not that. It is the fact that all of these patients live in communities where people right, left, and center have died of the condition. Young people have died of hepatitis delta infection, and they know it. And therefore, the context is important. The motivation to get therapy, any type of therapy which would be helpful, is important. And that's why I think that was the reason for our success. Despite the fact that they had to travel between 150 to 300 kilometers every 2 weeks to come to us for 1.5 years, we've had only two dropouts, whereas the dropout rate elsewhere was something like 18 or 19%. This speaks to the context and relevance to patients and their families. So that was the success, not something that we did, but something that these people had lived with, had the lived experience of their communities and their families and so on. So it was so nice to see that when they were coming in with their infusions and so on, there was a sense of community. So everybody was supporting each other. So there are 5 patients lying in front of you, getting an infusion, and they're saying, Dr. Sahab, usko zara dekh lena, usko thoda sa rash ho rahi hai. Ye bata nahi raha, lekin isko thodi rash ho rahi hai. Usko dekh le. There was, and they did not know each other. They were coming from different areas, but there was a sense of community that developed, which is really very, very interesting to see. Female patients, they are being brought along with a male relative, and there is a patient's brother who comes with her every 2 weeks. So leaves work, comes with her for every 2 weeks, and that is something that was a success story. So Another success story was the vaccine, the first vaccine trial that we did in Pakistan for COVID. Lots of patients, about 13,000 patients. We put in about 3,000. And this was again something that was driven by patients or by subjects, not patients, by subjects and their families and other people. So this was so much word of mouth that fueled these studies, that it was important for those first few patients to come in through the door, and then those patients to be, or subjects, not patients, or subjects to be acting as ambassadors for the rest of the crowd. I'll need another 5 minutes, please. But then let's talk about some failures. And the failures were the COVID therapeutic studies. We had 3 or 4 COVID therapeutic studies right at the start for severe disease and other classifications, but we failed miserably in recruiting for these patients, for these studies. Do you know why? Because these people were completely isolated. Families were not allowed to meet them, right? They could not interact with the family. You went to the patient and you said, would you want to participate in a trial? He said, well, I will have to talk to my family. The trouble is they can't talk to the family because the family is not allowed to go into those rooms or units. And families, when you talk to the families, they were not willing because they had not talked to the patient or sought their advice and so on to volunteer their patient for the trials. So this was something where we failed miserably. So just a few other random thoughts, basically. That the patient perspectives are important. And one of the most important patient perspective is the balancing act of trial participation. Now, when we are in a trial, we are so much focused on the mechanistic parts of the trial. The patient is coming in, getting the blood draw, getting the investigation product, getting all the measurements and so on and so forth, notes, likhe ja rahe hain, everything is there. We just tend to forget the patient in the middle of all this. And that's why that is called what is called the participation in a trial versus life balance. Please remember these patients also have another life. It is not just the trial life, but it is also another life that they have to live and earn money or look after their families and so on and so forth. So participating in a clinical trial can be arduous, a demanding process, requires a significant commitment of time, energy, and emotions, and even their caregivers have to go through a great deal. So remember the balancing act of these things. So what is happening? What is changing? What is changing in the area of clinical trials? People are now thinking more and more in terms of patient-centric clinical trials, right? And what do we mean by patient-centric clinical trials? And the basic meaning is that you engage in, first of all, you engage in meaningful discussions with patients about these studies, about the disease that you're doing, recognize each patient as an individual with a unique cultural background, establish common grounds with patients to collaboratively manage the disease. And I think all of these points were covered in the Delta studies that we did or we are doing. We didn't have to really move a muscle, and all this thing was automatically there, right? So how do you set up a clinical trial that integrates patient-centric care? The aim is to get a representative sample of population first, be as inclusionary as possible. So look after the exclusion criteria, try and get rid of those inclusion criteria as much as possible, and get as many people into the study. The other aspect is the financial part. Now, again, the criticism is that patients are paid money to do this, and therefore this is not right and not appropriate. It is the money part has to be looked at by individual ethics committees, and you have to justify what the money is, how much money is to be given. For example, in our Delta patient trials, we were giving them bus fares or train fares to come and go, and something to eat on the way. So the routine was they would start at night, late night, get on a bus, get on a train, come up here in the morning, come to our unit, get the whole thing done, and leave in the evening. So and get back home the next day. So it's about a 48-hour process altogether. So you need to be fair in giving them the money. And midway during the trial, people came to us and said, "Doctor Sahab, bus ka fare to aapne itna lagaya tha, ab to wo double ho gaya because the petrol prices have gone up." So we had to adjust, and we had to say, "Fine, we will do that." So please remember, the financial aspects are important for patients. They leave their jobs and they leave their homes. The other aspect of patient-centric studies or trials is to decentralize them. And there's a lot of work going on in this area. There's not much time to talk about this, but a lot of technology is involved or can be involved. Many trials can be done safely around at the patient's home or around the patient's home, particularly the follow-up visits and so on. So I think this is something that needs really a focus. The use of social media platforms is extremely important. I've seen that video, which is fantastic. Congratulations for it. We will borrow it from you if we can and run it for our patients also. So remember, the social media platforms are extremely important. Lastly, just a plea to remember the whole person. So remember that participation and trial life balance. So that is critically important, and that will what will keep these patients engaged. Don't forget about the journey, right? Finally, there's this FDA guidance which came out in February 2022. Please read it. It is patient-focused drug development. Gives you many thoughts and ideas of how you can create patient-centric trials for various situations and various diseases. With that, I'll thank you for your attention, and we take questions now or later. Okay.
Thank you so much, Professor Said. That was an excellent presentation and ties in really well with the work that we're doing. Because when we talk about patient-centric trials, one way to design those patient-centric trials are PPIE groups, and is through the involvement in patients and those with lived experiences. So thank you very much for sharing. We will now start our sessions with all the talks of our speakers. Each presentation will be 15 minutes long, with notifications given to the speakers at the 10-minute mark and the 1-minute left mark. We would really encourage that all the speakers stick to their allotted time, just to make sure that that the flow of the session is not interrupted. If anyone has any questions during the presentations, please, you can scan this code. You can post all your questions on Slido, and we will try to address all of your questions during the panel discussion. So please post all of your questions onto the Slido app once you scan this QR code. Again, so to start, we have our first speaker, Mr. Adnan Masood, who is a banking and technology consultant, but he has a deep commitment to research in adjuvant cancer therapies and patient advocacy. He is a key member of the PPIE group at Ziauddin here, and he's going to come here and talk about the need for the patient voice in research. So please, everybody, if you can give a warm welcome to Mr. Adnan Masood.
Assalamualaikum. So, although my background is banking and technology, I did enroll in Ziauddin University, but I dropped out and I went into computer science. And then through patient advocacy, I started my patient advocacy journey in cancer research, and that made me a great, passionate patient advocate. I have a blog by the name of Targeting Cancer Metabolism. I do urge all of you to check it out. It's all based on published cancer material, PubMed and medical journals. So no voodoo science there. Often हमारे culture में culture अल्लाह की जो मर्जी थी, especially in the medical field, कुछ हो जाता अल्लाह की जो मर्जी थी हो गया. You know, this was what God has ordained. But there's a wonderful prophetic parable. Some Bedouin once came to the prophet and said, "How should I practice tawakkul?" And the prophet said, "Trust in God, but tie your camel first." And we forget to tie the camel. That part is left out. Just trust in God is emphasized, And tying your camel first is left out completely in all phases of life, in all spheres. And that makes us, it reduces the quality of our life, of a patient care, of everything. So when I said what is patient advocacy is basically tying your camel. Not be satisfied with what you have or what the prescribed path is, but to do the extra mile, to do the best that you can. What is the definition of patient advocacy? It is the process of promoting and protecting the patient's interests and ensuring that they are receiving the best possible care and treatment. That's the medical definition. So that is the goal, and that is not achievable except by the active involvement of the patient and the patient caregiver. The root meaning of the word patient comes from the Latin word patience, which means suffering and enduring. And it's derived from the word pati, to suffer, to bear. आप देख सकते हैं, even the word patient means a passive acceptance of everything. It's like the hundreds of thousands of years of culture has programmed us to just accept everything. And patient advocacy is basically moving against this cultural bias that has come up for hundreds of thousands of years. Patient advocacy is a stream against this cultural bias, this passivity of accepting everything. And the patient advocacy, I launched into it, and I discovered that through patient advocacy, you can have dramatic improvement in the patient care and in since मेरा ज़्यादा cancer research में रहा है, in the cancer survivability rates. And I'll show you some of the examples here. How did my own journey get into patient advocacy? It was through a movie on Netflix. So Netflix is not all bad. There's a wonderful documentary called The C Word. It's a documentary made by Megan O'Hara. This is a wonderful line for this: time for cancer to be afraid of us. I urge all of you to go and see it. And when I saw it, it just blew my mind. And after that, उससे करीब करीब मैंने एक YouTube पे देखी एक TEDx talk देखी. And मैं सबको कहूँगा कि this will be the best 20 minutes to spend your life. Watch that TEDx talk by Dr. William Lee. It changed my perspective on food forever. It's called Can We Eat to Starve Cancer? It will completely change the way you look at food. Dr. William Lee was an assistant to Dr. Judah Folkman. Dr. Judah Folkman ने बहुत काम किया था regarding angiogenesis. I don't know if you know, angiogenesis is the science of attracting blood vessels to cancer cells. So Dr. Judah Folkman discovered angiogenesis, and it has now become one of the 10 hallmarks of cancer, angiogenesis. Dr. William Lee was actually an assistant to Dr. Judah Folkman. And Dr. Judah Folkman का जो काम है, the result of that work is that cancer medication like Revlimid and Avastin are based entirely on his work, Dr. Judah Folkman's work. So Dr. William Lee has worked on how food can affect angiogenesis, how food can block cancer vessels from migrating towards cancer cells. It blocks the blood vessels from migrating towards cancer cells. So it's totally based on science, and it completely blew my mind. So so there were several cancer patients that I came across who would go to oncologists and who would discuss their thing with oncologists. And when the topic of food would come, the oncologist would say, no, eat anything. And that this is completely counter to what Dr. William Lee has saying and which he has proved. So Dr. William Lee has made a list of all the food items that are almost as impactful as some of these cancer medications, Revlimid and Avastin. He's now written a wonderful book called Eat to Beat. I urge all of you to read it. Every food has an impact on your body. Whatever you eat, it has an impact on your body. According to Dr. William Lee, everybody in this hall does have cancer cells, but our immune system kills those cancer cells as soon as they arise. If you eat the right kind of food, then those food items are actually blocking the cancer pathways and not allowing the cancer to. And I have actually, there's tons of now patient advocated case studies that show that this has a deep impact, that it has proven Dr. William Lee's studies. Anyway, that blew my mind. I said, if patient advocacy can have such a huge impact, and that led me to read literally hundreds of books on cancer survivors, and that's made me publish the blog that I have, targeting cancer metabolism. Briefly, the power of patient advocacy. There was a study conducted called the EPAC study, engagement of patients with advanced cancer study. The EPAC study was randomized, controlled, 10-year study involving patients with stage 3 or stage 4 disease or recurrent cancer. Investigators randomly assigned patients into usual care alone versus advanced care planning intervention plus usual care. The intervention included bi-weekly telephone sessions over 6 months delivered by health workers to engage with patients and caregivers on how to improve care and treatments. This 10-year study showed what a huge impact even this minute amount of patient advocacy has. It'll just blow your mind, the results that came out. A stunning 25% reduction in cancer mortality in 2 years, just through patient advocacy. Now, if अगर कोई ड्रग सिर्फ 3% भी improve कर दे cancer mortality, FDA उसको approve कर देती है. And here's a 25% reduction in cancer mortality. That's just mind-blowing. Look at all those drugs. जो नई drugs आती हैं, आप देखते हैं वो आता है newspaper में आता है. It's the best possible thing that happened in cancer. But when you look at the details, they're improving cancer mortality only by 2%, 3%, 4%. Even the latest immune therapy drugs that are coming out. And here's just patient advocacy is having a stunning 25% impact. And a whopping 20% net reduction in total healthcare costs in the intervention group. Now, briefly about patient advocacy in research. Some of that material has already been covered by the wonderful presentation of Professor Hamid. So, the clinical trials that are involved in research must ensure research relevance and validity. They must enhance participant safety and well-being, help improve patient outcomes. They shouldn't be theoretical works. They must be centered around patient-centric issues. This ensures participant recruitment, engagement, and retention. And that fosters trust and transparency. That has been covered well by Professor Hamid as well in the last 3 of his slides. The challenges are addressing power balances. All of you clinicians sitting here and doctors, this white coat has a lot of power. You don't know how in awe a patient is of this white coat. So, वो आदि चीजें तो बोलता ही नहीं है, and you don't get to know the issues of the patient. You don't know how popular those doctors are who are approachable. So if you talk among patients, the most popular doctors are those who are approachable. So this white coat has a lot of power. If you use it properly, you can have a dramatic impact on the outcome of the patient. So we need to bridge that gap. There's the white coat power needs to be used appropriately. This is a real challenge, ensuring diverse patient representation. ये हमारे PPI group में भी है. So we don't have a very diverse group of people. So that is a challenge that we must address in our PPI group as well. And I think हमारा PPI members की capacity बढ़ रही है from 5 to 10 now. And of course, Professor Hamid has covered it, learning technology. I think we're lagging behind. वो हमारा PPI group में the participation initially was very erratic, but once Arisha introduced the remote setup, it had a dramatic impact, and we made dramatic progress. That's a very small example of how technology had a dramatic impact on our own PPI group. Here are some renowned examples of case studies which were started by patient advocates and which were where patient advocacy led a key role. The Komen Tissue Bank, this they discovered that one of the key things that was blocking breast cancer research was the unavailability of healthy breast tissue. So one of the patient advocates started it, and that led to one of the big banks, Komen Tissue Bank. The Breast Cancer Environment Research Program, again, a US-based research program, investigated environmental factors that were affecting breast cancer. And this, again, patient advocates initiated it, designed it, documented it, and disseminated the studies. The Breast Cancer Research Stamp was a movement to collect funds for breast cancer. Again, patient advocates played a huge role in this. I'll end with a personal patient advocacy success story. So I'm a student of St. Pat's. So I have a school friend who was diagnosed with third stage bladder cancer. And so among my friends, people know that I've done some research in cancer. And they directed him to me. And he's in the US. And I was in a conference call with a US oncologist. And he said, we are recommending bladder removal and chemotherapy and radiation. And the outcome he gave was, he had the 40-year technically, he said about 25% 5-year survival rate for stage 3 bladder cancer. So that was devastating news for a guy who was 52 years old. So I sat down with him, I discussed things with him, I brought all my research work to him, and he discussed that with his family and everything. He said, if I do all of these things, they're giving me only 25% chance of survival. So what do I do? One of the things that he was not in favor was surgery of bladder removal. He said, if I remove my bladder, that's it. My life is finished. It's gone. I won't be able to do things that I love. So we charted out a plan for him. And all the works of Dr. William Lee and all the other cancer researchers out there are literally out there which are collated in my website. We applied it, and the result was phenomenal. He did not remove his bladder. He had chemotherapy, radiation. He had a complete lifestyle change. 6 years have gone by, and there's no evidence of disease. So that was a huge success story for us. Thank you. Thank you all. That's it.
Thank you so much, Mr. Adnan. Yes, please. Would it be possible for you to just scan this code and then post your question on Slido? We'll take it in the panel discussion. Thank you so much. Thank you so much, Mr. Adnan. I mean, it's always a pleasure to hear you speak, and especially the passion that you share for patient advocacy. It's really incredible, and that's one of the main driving forces of our group as well. So thank you so much for all your contributions always. Next, I would like to invite Dr. Rakshi Memon on stage. Dr. Memon is a research fellow at the University College London and a prominent voice in bioethics and community engagement. She also serves as the chair of the CEI group, the Community Engagement Involvement Group at the Pakistan Institute of Living and Learning. Over the past few months, we've had the privilege of engaging in regular discussions with her. And today she's here in person to share with us to share with all of you what she's been sharing and teaching us. So please, a warm welcome from Dr. Rakshi.
Thank you very much. Assalamu alaikum and good afternoon. I'm so excited to be here in person because we've been communicating every week in the CEIE group at PIL, which Arishi is a very prominent member and integral member. So thank you for inviting me. And also, I'm so grateful to Professor Naseem Chowdhury, the CEO of Pakistan Institute of Living and Learning, as well as my research team, who are the real workers, who are the ones who work on the ground, and they work in the field, and I'm just here honored to be representing them to give you some of the taste, some of the work that they've been doing over the years. So Pakistan Institute of Living and Learning has been conducted, and it's commonly known by the acronym of PIL. So I will be calling it PIL. It's been conducting mental health research for over 20 years now in Pakistan, but also now globally. It's a major mental health research center. And as Pakistan, you know, we are very proud to be sort of flying the Pakistan flag globally, especially in mental health research. So I'm just going to, we take a life course approach for mental health in the research projects that we conduct. So I'm going to talk a bit about that. I'll also talk about some of the community engagement and involvement activities and the impact of them that we have in Pakistan from the perspective of CI, and the wider impact of CIE and in low resource settings as well. So I'll talk a bit about our partner countries as well, and then our way forward in collaboration with Ziauddin. So we've been doing some work together. So as I say, our research takes the life course approach for mental health, and I've got Serish here helping because I have a disability. I have shaky hands, so she's helping me with that. So we start from the preconception and do work maternal as well as child health, and go across the life over to older adults as well as the elderly. And what I'm going to try to do is take my CIE journey as well with the life course approach. I may not be successful, but here we go. So first, I'm going to just talk a bit about the preconception pregnancy and mental health. And just one of the trials that we've been doing, that's learning through play, which we culturally adapted. And when we started, we chose Gadaf town, which is part of Karachi. And you may ask why Gadaf town? We consulted sort of government organizations, NGOs, other agencies as well, and they identified Gadaf town, which has the gown culture. So if you have the gown culture, you need to really make sure that the male members of the community are also engaged. So the intervention was for women, but we first went to the male members through our community health workers, through our community champions, as well as community partnership advisors. And they did a great job. They engaged the men, and we got access to the female to be able to do this work. I'll just talk a bit about, I can talk about this for a whole day, but I won't do this because I know Arisha won't be very happy. We use a standard framework when we are bringing about change and we are planning and doing a stakeholder engagement, which is a framework, theory of change framework, which was developed by Paulo Freire. And most of the things that Professor Hamid said, they really resonated to me because it covered all the components. But it is very much bringing people with their lived experiences, and we all sit around the table and we actually try to develop and plan and try to look at things through the lens of the end beneficiaries. So that's the theory of change framework that we use before we start planning every trial and project. So now going back to learning through play, the impact we had, the learning from it was that we were told by the participants that we should have a 0 session as well. It has 10 sessions and it's a manually assisted, culturally adapted pictorial manual that is taken to the female participants, but what they said, they needed a zero session where we could actually engage families as well and other members, so that if when we are doing the sessions, there could be babysitting facilities as well, and the whole family is engaged. So that was the learning that we got after the first one. Then CIE members voiced the importance of parenting from the father's perspective. You know, it was so amazing. The fathers themselves came forward. They knew that, you know, there was change, good, positive change coming into their partners. So they said, why can't we do it? So we put a grant in with Grant Challenges Canada, which was successful. And at this moment in time, we are analyzing the data for that. Yes. Also, as I said, our lived experience experts are the integral part. In fact, they are the ones, you know, who are leading our projects as well. And they go through the whole life cycle of our projects as well. So we have these two lived experience experts who actually have become our colleagues, researchers as well. As I said, they followed the life cycle and they went to Tanzania to this event and won the first prize. So we are really excited about that. Again, childhood and early adolescence. So we've been doing quite a lot of work with schools as well as other young people on substance misuse and also self-harm and suicide prevention. And when we went to schools, actually, what happened, there was some resistance from the school administration, but we had put together a young people's group. And what had happened that these young people actually engaged the administration, and they said, the administration said that, you know, they might be labeled and there might be stigma, because there is stigma with mental health. But the young people came forward and said, we want to talk about it. We want to raise awareness. And they actually produced really good campaigns and material as well. So now we've been working with the communities as well, but we wanted to influence the policymakers as well, because until you produce some evidence base and take to the policymakers, I mean, however much you think that change will happen, you need to actually be able to really change some regulations as well. So here what we did was we worked with stakeholders, policymakers, of course, lived experience experts and other stakeholders and collaborators as well. And we produced national guidelines for suicide prevention. These guidelines have actually now been launched in the Sindh province. So Sindh is the first one to launch these guidelines for suicide prevention. Okay, so as I'm going along, I'm now getting to adults and also to the older people. These are the activities that have been happening with our adults. And with the adults, I think we had to be, our research teams had to be quite flexible and diverse as well, because of course they are at working age, they are the breadwinners as well. So our research teams and field workers had to go sometimes after work and do the screening, etc. But once you know, they had trust in you as well, they would sometimes even give up their one-day livelihood so that they could be part of the sessions that were happening. So now here we have, you know, we've been very focused with mental health up till now, and all our research has been in mental health. But we have now expanded into multi-morbidities as well, bringing in the psychosocial component into these different trials. So we're doing a very large trial on burn injury, and last year, and that's bringing in the rehabilitation component into it as well. We did a very successful winter program, and this winter roadshow started from KPK and came all the way through Lahore and Rawalpindi and Karachi as well, Balochistan. And this year we're going to do it again and launch a national burns day. We've also done similar work with okay, I have time. I don't have to rush. Thank you. So we are also doing some work on cardiac rehab. And again, we're doing similar sort of community engagement and involvement activities on this. Oh, yes. I had said to them, I have this habit of walking away. Well, so they have kindly given me advice. Can you all hear me? Yeah, great. So the other one that is on up here, we're really proud of. Again, these are NIH grants that we have successfully got. And this is moving on ABC, which is breast cancer survivors. And they've been doing our lived experience, experts have been doing child and chat. Over because PPIE has got 8 centers across the country. And so again, our service user groups as well as community advisory groups are quite diverse. Okay, so I've talked about the community advisory groups, and because, you know, we get engagement from the ground up, we get a lot of recruitment and retention because, again, as I think Professor Hamid, as well as you said, Professor, that when the community is engaged, they themselves really sort of influence their other community members. And here, again, we're really proud of working with the government. We had a mental health summit at the President's House, and we, with lived experience experts as well as other collaborators, but I think Phil has played an integral part. I mean, you know, blowing our own trumpet, but I think we have to be proud of it. We did change the law and we do know that. So now, as you know, we have from the beginning used evidence-based frameworks to do community engagement, but we wanted to do take a more scientific approach to community engagement and involvement. As you're hearing that we do a lot of global projects, and with the WHO Global Health Agenda, as well as the UN Sustainable Development Goals, researchers in the West have become very interested in global health. So we find that we were bringing quite a lot of Western visitors here as well, who wanted to get involved in community engagement. So what we thought was we are going to have a discussion group with our local field researchers. There were 32 researchers who gave up their time to me. And we wanted to find out from their perspective what differences they felt there was. And 5 teams came out, and you would see here, you know, something around notion of respect and trust. One of the comments that was made, you know, was just around eye contact. So in the West, if you don't give somebody eye contact, then what happens is you're being here you give eye contact to an opposite gender, it's not very good. And also elderly, that's disrespectful. Okay, I think I have to rush now. But this has been published, so you can get that. Yes, so I'm going to just now talk about our community engagement and involvement group. So again, we have developed the vision and the mission with our service advisory group and our community advisory board. So you can all read that. And we are working on 5 objectives, and each work stream, we also have service sort of service users who are part and parcel of the work stream work that's happening as well. And what we wanted to do is really use quite a lot of community engagement frameworks that are given sometimes by the funders as well. But there's some things which are not really culturally relevant. So we thought, let's think about developing a concept map that is going to be relevant in Pakistan as well as other low and middle income countries. So what we did was we wanted to do a scoping review, but we found that there was one already done by Anna Maria et al. In 22, which was quite recent. So what we have started doing is we've been doing quite a lot of campaign work as well as consultation with our own service user groups, as well as we've involved our partner countries such as Sri Lanka, India, Turkey, Nigeria. We are supporting them to develop community work as well. And they are all, we are talking to them on the principles and values, and we are writing the narrative that they are bringing to us to this country update. So that is a piece of work that is happening as we speak. Rishi is very much part of it as well. And this is the concept map here, which we are trying to co-adapt with our service users and our lived experience experts as well. And here, you would have heard about or read the Nigel Fish, turning the world upside down is really to go ground up and make this thing happen from ground up. And these are the countries that we are collaborating with. India's continuing quite a bit as well, because they are quite advanced in community engagement, but the other countries we are supporting quite a lot. With the learning, going forward in all the countries. So I think here I just wanted to summarize that we are having an integrated capacity building approach, not really just with the researchers, but our lived experience experts and researchers as well, and building this capacity into our communities. So global health collaboration, I think these 3 pillars, research, ethics, and CI, is the cornerstone of it. This is really my colleague, Professor Abdullah, exit model, and I think it's it. So I have gone just, I think, a minute over. Sorry about that, but thank you. And this is just a verse from the Quran, and whoever saves a life, it is as though he has saved the lives of the life. Thank you so much.
I will put this back up for anybody who wants to scan. Thank you so much, Dr. Maiman, for that. Thank you so much, Dr. Maiman, for that wonderful presentation and showing all the incredible work that you've been doing. Our last presenter today is actually joining us online. And Dr. Ashley Cheen is an expert in patient and public engagement at the University of Oxford in the Pandemic Sciences Institute. She also serves as the PPIE lead for the Health Protection Research Unit in Emerging and Zoonotic Infections. It's such a mouthful. She will be sharing the UK's perspective on community engagement. Dr. Ashley Cheen. Just the second, Ashley, where?
Thanks.
Just a second.
I think it's working now. All right, thank you very much, and thanks to all the organizers for inviting me to speak today. It's been a really great session, and I've loved hearing all of the other talks. Today, I'll be talking to you about the UK perspective on community engagement. I do work on global community engagement, but I think I'll just give you a bit of perspective from a different setting. And I wanted to structure this talk, it's quite a broad topic to talk about in 10-15 minutes. So I've kind of structured the talk to start on a few of the key pieces of infrastructure and resources that we have here in the UK for PPIE or community engagement, before talking a little bit more in detail about a particular case study that I've been involved in. So just starting off with some of these key pieces of infrastructure. So here in the UK, we have kind of set clear strategic goals for PPIE and in these UK standards for public involvement. So these were 6 key standards. You can see them here in this figure, and they are essentially like different types of values, and kind of, you could think of them as pillars in how to structure your PPIE activities. They've been developed in 2019 over several years of previous consultation and testing by the 4 UK national research partners. And they are generally advised to be used as kind of building blocks, as I said, in developing any PPIE strategy, no matter if this is for an individual study or for strategic PPIE strategies for an institution, for example. So they're very broad-ranging standards. And so we're very lucky to have these, and I think this has been a really great start in the UK to try and become a bit more standardized in how we do PPIE and consistent across the country. I will highlight that there are still some challenges with these values, namely the first one being that they were developed pre-COVID times. So obviously quite a lot has changed since then, and perhaps how the public and researchers both feel about these standards may have changed. And in some cases, they're a little bit unclear on how to use these standards. So for very particular studies, and of course, as I've mentioned in the title, this is UK specific. So there's obviously a question on, do these apply to other countries? And if you're a researcher in the UK doing global health research, can they be used? Or are different standards more applicable for different settings? And then also just to highlight a few of the other key resources we have here. So funding is a big priority. Funding for PPIE itself is a big priority here in the UK. So we have many UK-based funders. I've listed a few of these as an example. It's not an exhaustive list here, that have really prioritized PPIE. Particularly, I'd say the NIHR. So this is the National Institute for Health Research in the UK. And they are a really big kind of champion for PPIE here. So in almost any grant that they fund, they require groups to describe how they are going to do PPIE within their project. And it's almost compulsory, I think, at this stage. And then some of their larger projects where they set up programs and units of work, they also require PPIE staff to be standalone and built into projects, which is, I think, a really great push. And I think these funders pushing for PPIE has made a real difference in the country in general and how we approach PPIE in our research. I'd also like to highlight that evaluation and communication of PPIE is also a big priority here. And for example, we have several UK-based journals, which require, again, authors to mention whether or not they have involved patients in the public, and if not, why that might be. We also, in case anyone hasn't come across this before, have specific journals just for research involvement and engagement and PPIE. And I think this is the only journal that I'm aware of that publishes exclusively on this topic, which is a really great step. And we also have a number of resources here for contributors or patients and members of the public to get involved in research. One of the main ones being the People in Research website, and this is a screenshot from this website you can see here. And this is a really useful site. It's essentially like a jobs board where a researcher can go in and post their involvement opportunity that they want patients or members of the public to be involved in. Or a patient or member of the public can go onto this website and look at all the different opportunities and kind of select the type of research that they want to be involved in. And I think this has been really helpful in recruiting lay members and members of the public to get involved in research. But I would like to highlight, although we have a lot of these resources and it's really great, PPIE is still not universal across research groups in the UK. So for example, when I was doing my PhD in tuberculosis research in the UK, I had actually never even heard of the term PPIE before. And none of my colleagues or friends had talked about it or heard of it either. So we still have a long way to go in kind of standardizing this across applicable studies in the UK. So now I want to talk a little bit more in detail about a specific case study and how you could go about doing PPIE here with the resources that we have. And the study I'm going to focus on here is in the context of the UK Mpox outbreak. So this was an outbreak back in 2022. We still do have cases, so it's still technically ongoing, but here in this graph, you can see the main curve of the outbreak that year. So it started in early May, peaked in the summer, and then the case numbers decreased by September. And this was obviously quite a short outbreak, even though we've got still lingering numbers at the moment. But this was the first time we'd ever seen sustained transmission in the UK. And as a result, our team set up the first treatment trial for Mpox called Platinum. And here we were, this is a randomized controlled trial that we set up. And it was to test tecovirimat, the treatment, in non-hospitalized Mpox patients. So those outside of hospital. And I think this was a huge challenge for us, particularly with the timing and how rapid outbreaks obviously can often be. You saw the curve, it was quite short-lived, but at the very beginning, we had to be very, very quick. So the call for starting up this trial actually gave us, I think it was 72 hours to prepare our protocol and our PPIE plans and essentially everything that we would submit to run the trial. And so my job was to, first of all, come up with a PPIE plan in 72 hours. And also, if I could, try and find a patient representative or a community representative or community member who could review some of the documents in that time. And I was very lucky that I did find some people to help at that stage. Which does show that sometimes in the right setting, you can do PPIE at a very rapid pace, but it's definitely a big challenge. And I was definitely, I think, quite lucky in that situation. And so I wanted to highlight, these are some of the activities that we did as part of this trial in relation to PPIE. And I'd say the two key activities that we set up was, first of all, talking to community organizations. So in the UK, we have, we're quite lucky, I think, that we have a lot of kind of patient advocacy groups. We've got a lot of community organizations and NGOs. And they were really pivotal in those very first steps and throughout the rest, but crucially in those first steps in setting up the study. Because a lot of the people who work in these organizations are perhaps used to talking to researchers and used to reading research. So they already kind of understand the language that we're using, and so they can really help advise us on that stage. And the other critical part was setting up our community advisory panel. And this panel consisted of Mpox patients, friends and family members of patients, people from the wider community, and also healthcare workers who were treating Mpox patients. And they essentially guided us in deciding the rest of the PPIE strategy for the rest of the trial. And we're still, involving them on related studies to this day. And so some of the key achievements I've mentioned already, early and rapid involvement at the start of the study. We made some changes to the trial protocol very early on, which were really patient focused. So for example, we included a 24-hour phone number for any participant in case they needed help at any time. We had a much more significant increase in awareness at trial launch, and this was a huge part to the PPIE and the community organizations. I think we had about 1.4 million potential Twitter engagements at one stage because so many different organizations were sharing our posts, which was really amazing. And it's important, of course, to evaluate your PPIE. And we've had some really positive feedback from the communities and the community panel. I do want to highlight that there are always challenges, and this is no exception, particularly with PPIE. There are sometimes things that are outside of your control in research, and that's just something that we have to be able to communicate to the community. So in our case, although our team was very ready at all times to get started with the study, there were some slow approvals in terms of setting up the study itself with some of the partners we were working with. And this meant that, unfortunately, our study actually only launched towards the end of this curve. Of course, we didn't know how the outbreak was going to shape out, so we didn't know that the cases wouldn't necessarily rise again to the same levels. But this was a cause of kind of tension with the community organizations that we were working with, that we didn't get ready fast enough. And I think that, there's some lessons here about how the community understand how research works and how fast we can work in research and how it actually takes in reality. And so just to finish on a few points for PPIE and future outbreaks, I just wanted to highlight that there is a very deep body of knowledge and experience about engaging people. And these are some of the key resources that I use, particularly around global PPIE. So they're not at all UK-centric. And I'm hoping that very soon in the future, at least in the UK, we can get to a point where we're really standardizing community involvement in research across majority of studies where it's relevant, rather than this ad hoc situation that I think we've got at the moment. I think there's more that we can do. And just to finish, acknowledging the study team, the community advisory panel that I mentioned, supporting community groups and the trial participants. And thank you all for listening.
Thank you, Dr. Ashley. I just found out that you cannot hear the applause. So we have about 80 people here who are applauding very nicely and very loudly for you because that was an excellent presentation. So thank you so much.
Thank you.
And really wish to welcome you in person someday for future collaboration. So thank you.